The next 30 to 35 minutes, hope to cover really what key drivers are about, their importance in improving hypertension control, give some examples of why we think this approach is proven. It's an evidence-based approach, both from a systems perspective, but also look at some individual specific key drivers to show their importance as well. And then to wrap up with how we incorporate this work in our HEARTS program in the region of the Americas. So I want to start with just some background slides, which I think are level setting, and this is known to all of you. This is data from Statista. The CDC has not updated their average daily death data for 2021 yet, but this gives a preliminary idea of the importance of cardiovascular disease in spite of the horrific pandemic that we're going through. So the gold line there are daily deaths from CVD mortality. The pink, which is lower, embedded in a couple of others, is stroke. And so we know that blood pressure accounts for about 50% of the cardiovascular mortality. So even in the setting of a horrible pandemic, cardiovascular disease and specifically blood pressure is really accounting for a huge burden of mortality and morbidity. And we know that the United States is not doing well. So this is data that has, I think, is known to all. This is NHANES data looking at 2-year cycles. And as you can see, over the last 4 years, the latest 2 NHANES cycles, blood pressure control has dropped dramatically, about 10% to the low 40s, which is really a very suboptimal level of performance for a country with such high resources. And this data was updated very recently, just a couple of weeks ago in Hypertension Journal. And this is NHANES data as well, but now we're looking at 4-year cycles. The reason being that the traditional 2-year cycle, which would have included all of 2020, had to be cut short because of the pandemic. So what they decided to do, because the sample set was not big enough, was merge it into 4-year samples. But we see the same lessons here from the prior NHANES data. Essentially, the blood pressure control in this country is falling significantly, as you can see in the top left, and very worrisome as well when we look at specific demographic trends. I think these are very notable and concerning as well. So women used to have higher blood pressure control rates than men, but they have now fallen fairly precipitously over the last 6 to 8 years. And then elderly as well, greater than 75, have fallen dramatically. And our Black hypertensive patients, we are also seeing significant drops in blood pressure control. So we have to be aware, cognizant of these very important demographic trends as well too. Now, that's the bad news. The good news is that high blood pressure control can be achieved. And I'm showing 2 examples on this slide here. On the left is my region in Kaiser Permanente in Southern California, which had dramatic improvement in blood pressure control over the course of 6 or 8 years in the first decade of 2000. And the Canadian experience, which is probably the best national experience, where they had about a 50% improvement in control over the course of a couple decades through the Canadian Hypertension Education Program. And as you can see, this was accompanied by a very significant decrease in cardiovascular complication rates as well. So not just blood pressure improvement, but decrease in outcomes as well. I just wanted to spend a couple of minutes for those of you who don't know, talking about the Kaiser Permanente program. It is the largest nonprofit health plan in the States with an operating revenue of about $100 billion. It's biggest on the West Coast, but we have 8 different regions across the country. And this just gives you a little bit of sense of the scale of both the national and the Southern California program, which is listed on the right. So in Southern California, we have about 5 million members with almost 8,000 physicians. This is a high-level look at the demographics within our system. We really do mirror the communities that we serve. So we're a very diverse medical group in terms of the patient population that we serve. And our hypertension registry is now approaching about 1 million patients. So one of the largest registries in the country. We do very, very high volume. That 2.3 million blood pressure checks a month was obviously pre-pandemic. Those numbers have fallen significantly, but a large-scale program. And this is a quick look at the demographics of the hypertension registry, which is a little bit different than the overall, because hypertensive patients are going to be a little bit older. and have different characteristics, but you get a sense for the diversity of our patient population within hypertension as well. And roughly half of our hypertensive population is in the Medicare population and half commercial. And this gives you a quick sense for how we've been doing recently. As all plans across the nation suffered during the pandemic, we had about a 16 to 18% drop in blood pressure control rates early in the pandemic. We've made up about 2/3 of that gain. So you can see the numbers are approaching 80% again, but you see some comparison across different product lines. Our biggest gap in performance is really young versus older hypertensive, which is an area of focus of ours. And this is our disparity or health equity data, which we take very seriously. At the beginning of this work, which we began about 10, 15 years ago, we had about an 8% black-white disparity gap. That has narrowed to about 2 to 3%, with similar disparity gaps across other racial and ethnic groups. Now, getting back to the topic in general, why do we think these high-performing health systems do well? And I'm going to hopefully show you over the next few minutes that in addition to just looking at blood pressure control, they really take time to identify key drivers that lead to that blood pressure control improvement. They translate those key drivers into process measures, and then they create a quality improvement performance feedback system with frequent data given to frontline clinicians and clinics. And as most of you know, there are 3 different kinds of quality measures. There are structural measures, which can be things like brick and mortar, physical characteristics. We tend to focus on outcome measures. In this country, what is the control of blood pressure achieved in a population? In our work in the other regions of the Americas, we look at coverage as well. That tends to be less of an issue in the States. But for the remainder of this talk, we're going to be focusing on process measures. So those are really the specific care delivery elements that lead to improvements in outcome. And those specific key delivery elements we call key drivers. The measure of those key drivers are called process measures. So I'm going to be using those 2 terms interchangeably. But they are a little bit different. And what's really important and impactful, I think, is that key drivers are under the direct control of the provider or clinic. So rather than just throwing population data at a clinic that they may feel they don't have the ability to impact, these specific process measures are directly under their control. So that's an important element in this work. Now, is the key driver process measure approach recognized, and is it supported by the literature? And I think the answer is a resounding yes. I'm going to show you first some studies from a system approach, which I think illustrate the process measure approach nicely. This was a paper published in the Journal of the American Heart Association last year, where they looked at 25 US health systems. They actually used academic systems in this particular study, and you can see the process measure approach that's already being exhibited here. And what they did was they just studied certain well-established process measures and looked at how well these systems were doing. And so you can see things that will be repeated during my talk, things like blood pressure measurement accuracy, treatment intensification, bringing the patient back in after an elevated visit, after a visit with an elevated blood pressure, and so forth. And what you can see here is not just the identification of process measures, but the opportunity to improve. So in this particular example, you see very suboptimal performance in process measures. As an example, repeating the blood pressure only occurred 23% of the time. So lots of opportunity. And then very importantly, from an equity lens, an equity perspective, rather than just saying a particular group is not performing well, this begins to give us data to be able to address disparity issues. So you can see across different racial and ethnic groups now, we can begin to identify what process measures are working well and what aren't. And that should allow the health system to focus more specifically on targeted efforts. So very, very important point as we begin to think about health equity in the hypertension world. Now, another nice study that's been quoted a lot over the last couple of years is a simulation study published in 2019. And it posed the question, how does the United States get to a control level of 80%? And they looked at three specific process measures or key drivers. So medication adherence, treatment intensification, and a return visit interval when the blood pressure was uncontrolled. And what you can see in the first column is usual care, and the United States does horribly in all of these measures. So medication adherence only occurs about half the time. Treatment intensification broadly only occurs about 13% of the time. And we're only bringing patients in roughly every 14 weeks. And you can see the best observed values from their study on the next column and perfect care. And what they did nicely in this study is they put this all into a simulation model, and they used this process measure methodology to say, how can we get to a control rate of 80%? And the bottom line is if we continue to do what we're doing, only 46% of those who are out of control will get into control, which is not where we'd like to be. But by varying these different levers, these different drivers, you can achieve an 80% control rate. And specifically, they found that treatment intensification was probably the most significant driver to achieve blood pressure control. And if you just ratcheted that level up to the 60% range or so, which is a daunting task, you could have significant improvement in control rates. So that's a simulation model. This is an actual on-the-ground clinical trial, which was done in South Carolina. A very famous study called MAP, Measure Accurately, Act Rapidly, and Partner with Patients. Really a classic QI study, which we like to use as a model. This was implemented in over 16,000 patients, and they looked at blood pressure measurement accuracy, treatment intensification, and partnering with patients, which was a little bit of a complicated variable, but essentially, how much did the blood pressure drop after treatment intensification? And they put this all together with a performance improvement methodology with monthly feedback to the clinics and the providers. And what they saw, no surprise, was a significant improvement of blood pressure control, which was exhibited at 6 months, but was sustained at 12 months. And nicely, what they saw was as the drivers increased, blood pressure control increased as well. So beautiful example of the process measure key driver approach. Now let's go back to the Kaiser model and dissect that a little bit to understand perhaps why the improvements occurred. So this is Northern California data, very similar to our region in the South. And what you can see here is an inflection point in 2005, where there was really an explosive growth, improvement in blood pressure control. Prior to that time, Kaiser was actually trailing the national standard, but then we had very significant improvement up to into the high 80s to 90%. So the question to be asked is what happened in 2005? And the answer, we think, is that two key drivers were implemented. Number one, we've always had a standardized treatment protocol, but before 2005, it was a stepped care approach. And in 2005, we began to use a fixed dose combination pill with lisinopril hydrochlorothiazide as the first step. And as you can see, as the use of the fixed dose combination pill increased, blood pressure increased as well too. This is not definitively cause and effect, but there's a nice correlation. And then the other key driver that was implemented was we uncoupled the follow-up blood pressure check from the physician visit. So instead, we brought patients back with a medical assistant or LVN within 2 to 4 weeks. And we think that was a very impactful key driver as well too. So that's the Kaiser system, a relatively high resource system in a very integrated, closed setting. Can this approach work in other settings? And the answer is definitely yes. This was a beautiful study done by the UCSF group where they adopted the Kaiser model and then put it into safety net clinics in the San Francisco area. So definitely an under-resourced setting. And what they did was essentially pick 5 key drivers. So an evidence-based treatment protocol, blood pressure check visits by a non-physician, some standardization of blood pressure measurement in a robust patient registry, and then a performance feedback system. And they essentially modified and adapted these key drivers so that they would work within the safety net system in San Francisco. And what they found over the course of 2 years, fairly large study with 16,000 patients was a significant improvement in blood pressure control. And then improvement really was seen across all racial and demographic groups. And as we saw in the South Carolina study, as the key driver improved, in this particular example, I'm sharing the use of a fixed dose combination pill, blood pressure control improved as well too. So some nice examples from a system approach that this is an effective way to think about blood pressure improvement. Now let's take a little bit of a deeper look into some individual key drivers, because then that allows us to think about which drivers we should be implementing. And I'm going to run through these fairly quickly because there are a number of them. But starting with accurate blood pressure measurement. So as I alluded to before, just repeating the blood pressure is a very effective process measure key driver. We know it's not occurring consistently across the states, but if you do so, as many as a third of blood pressures will normalize just with repeating. And this is highly supported by multiple guidelines, both in the States and outside. And so I'm going to give you some examples of how the Kaiser Permanente system approaches these drivers as well too. So this is an example of a key driver that we've implemented in our system. We think it's a very significant driver. It's easy to do, and we measure it monthly. So this is across 13 medical centers. And you can see that we do fairly well, a little bit of opportunity, but gives you a sense for how we approach this particular driver. Now, how about the use of an established protocol with a fixed dose combination pill? One of the things we thought really helped within the KP system. The evidence for this is very strong. We know that most patients require more than one medication to control their blood pressure, and that fixed dose combination pills have a long history of improving adherence and control. And when you do that, you decrease the length of time to achieve control. We also know there's significant opportunity. Fixed dose combinations, at least in this one study, and this has been borne out in others, probably is only used in about 1 in 5 hypertensive patients. And there's broad support for this across multiple American and international guidelines. This is how we implement this driver within our system in KP. We have a very linear, simplified algorithm, just focusing on the left-hand side. The right-hand side is just for those patients who are ACE intolerant or have pregnancy potential. And as I mentioned, we start with lisinopril hydrochlorothiazide in a fixed dose combination 20-25 milligram formulation. And we just go half to 1 to 2 pills. We add a calcium blocker, amlodipine, in the same methodology. The patients continue to be uncontrolled. We add spironolactone and then bisoprolol. Very simple algorithm. This works for all racial and ethnic groups across all comorbidities, ages, etc. So very easy to follow. And we know that a simplified protocol with a fixed dose combination pill has multiple advantages, as I've already mentioned. And the one I'd like to highlight just for a moment is that when you have a protocol that's very established, that everybody knows, it's very well socialized, you can begin to incorporate medication titration by non-physician providers, which I think is a critical part of any high-performing system. Now, how about treatment intensification? We know that intuitively this is an important driver, but it should be implemented and it should be studied. So in that same academic study that I quoted, they found that when a new medication was added, systolic blood pressure dropped by an average of 15 millimeters. I think this is a little bit high. Most clinical studies would show probably about a 10 millimeter gain, but to suffice it to say that this was found to be a very significant driver of blood pressure control. And we do this extremely poorly in the States. So this was a study looking at millions of patients, millions of visits. And what you can see here is not only is treatment intensification poorly done in the States, but that the trend is decreasing over time. So there's a couple different ways this was studied, patients on blood pressure medication and not on blood pressure medication. But in all groups, treatment intensification occurs poorly. So what we do within our system is that we use a team-based care approach. We actually create a separate blood pressure focus visit with a provider who is not a physician. It's the only complaint that's addressed. We only focus on blood pressure. We bring in all the relevant data, and then we strongly encourage medication intensification or titration whenever is possible. And we repeat that every 2 weeks until the blood pressure is controlled. Obviously, this can now be done virtually. in the setting of the pandemic or in person. And then we spend a lot of time socializing treatment intensification. We have specific data, which I'll show momentarily. We do a lot of educational programs around this in our system. We do academic detailing where champions meet with colleagues, and we share monthly data. And this is an example of our educational program that we have all of our new physicians and providers who are non-physicians undergo. So we use case studies and we look specifically for the big three categories of medications, thiazide and thiazide-like diuretics, ACE, ARBs, and calcium channel blockers. What are all of the potential issues that patients may have or concerns that providers may have, and train our providers how to deal with all of these so they're more comfortable not just keeping patients on their meds, but titrating when appropriate. We found this to be very helpful. So let's talk about medication titration by a non-physician. We think this may be the most effective team-based care strategy, and I'll show you the data in a minute. And in our global work, we know that this is imperative because there just aren't enough physicians to treat hypertension. So what is the data? This is a nice meta-analysis done in Annals of Internal Medicine a few years ago, where they looked at a variety of implementation strategies to improve blood pressure control. And the top implementation strategy found was team-based care with titration by a non-physician. So there's good, strong evidence for this with both nurses, but especially pharmacists, that this may be even a more effective strategy than team-based care with titration by a physician. This gets the highest level of support from the American Heart Association, ACC guidelines, highest level of evidence as well. And the WHO, for our work in the Americas, supports this as well too. And this is a big paradigm shift for many of the countries that we're dealing with. And this is just looking at the global gap in hypertension visits, a little bit less of an issue for our work in the States, but in lower resource settings, there just aren't enough physicians to treat hypertension. And so I said we socialize this very much within the KP system. We measure it a lot as well too. And you can see that that our data internally, this is unpublished, also confirms that treatment intensification by a non-physician is highly effective. So you can see that we run treatment intensification rates in the mid-30s during office visits with a physician. But when we use that BP focus visit with a nurse, the rates go up. And when we specifically look at systems that employ a pharmacist, it's the highest, the most effective titration that we have in our system. So very good evidence internally that this approach works. And so we create a standardized workflow. So when the physician sees the patient in clinic, their expectation is to titrate, if appropriate, if that blood pressure is elevated, and then to schedule the patient for a non-physician follow-up. And in that follow-up visit, the same process occurs. If the blood pressure is over goal, medication is titrated per protocol. They'll bring the patient back in 2 weeks, and this cycle repeats in a closed loop system until the blood pressure is controlled. So very nice, I think, workflow to implement. Now, how quickly should we bring patients back in has been studied, and we actually have some guidance now with some international guidelines, but this is intuitive as well. So this is a nice retrospective study done in Massachusetts, and you can see the dividing line occurs at about 1 month. So that if you bring patients back in 1 month or earlier, you can get control within a couple of months. But as that follow-up interval extends, it may take up to 6 months, a year longer to get that patient under control. And this has clinical ramifications. So this was also a retrospective study, but I think an important one to demonstrate the importance of bringing patients back in quicker. This was done in the UK. And what they looked at was cardiovascular outcomes based upon how quickly patients were brought back in and treatment intensified. And here the dividing line seemed to occur at about 1.4 months. In other words, if delays occurred past that point, then there was a signal of increased cardiovascular outcomes in patients. So retrospective study, but I think important nonetheless. And we see the signal in randomized controlled trials as well. I think this is inferential data at this point because these trials were not designed to actually look at time to control. But if you look at these 4 trials shown on this slide here, and you look at those patients who achieved control quicker, their cardiovascular event rate was lower. Now, a confounding issue with this approach is, of course, do patients who achieve control quicker, are they different in some way that we can't measure? And I think that is an important confounder. So this is inferential data, as I stated, but intuitively, I think it's important to think about this as well, too. So we think follow-up is critical. We actually use 2 weeks in the Kaiser system. We automate this so that if the physician forgets to make a notation, that patient's already booked for a follow-up blood pressure check in 2 weeks, and we measure it in all settings. So regardless of where the patient is seen, primary care or specialty or urgent care, we create data and reports to make sure that this is occurring. And I'll just talk very briefly about risk assessment. This is a huge issue in countries outside because we have a different goal based upon the new WH guideline, a 130 systolic goal in high-risk patients. We have the same guideline within the KP system as well. And I won't go over the data in detail, but there is strong evidence now in high-risk patients that a lower systolic goal is beneficial. And this has been borne out in other studies as well, too. This was trialist data published a few years ago, which very nicely display how you can achieve an equivalent reduction in cardiovascular event rate by lowering the blood pressure just a few millimeters in a high-risk patient. So last, I wanted to spend a couple of minutes just on the last but important key driver of creating a system for performance evaluation, putting this all together and creating feedback to your frontline physicians. It is definitely a key finding of high-performing systems. We see this in all the areas that we have studied. It's really the only way to evaluate if the key drivers that you have identified have actually been implemented. We think the feedback must be frequent, monthly is ideal, and it has to be drilled down to the individual physician or nurse. And I'll show you some examples of how we use a performance feedback system within the KP system. So this is an example of our 13 medical centers in Southern California. These are large centers of over 500,000 patients. And you can see some natural variation in performance, but the question again is, why is medical center A doing better than medical center B? And rather than just saying, well, our populations are different, we use the process measure approach to give us some more information. And so this is an example of that. So here are 4 key driver process measures that we study very intently in our system: repeating the blood pressure, treatment intensification, bringing the patient back after an elevated visit, and something that we call no BP, which is if a patient hasn't been seen in 12 months, they are considered out of control. And it's the medical center or clinic's responsibility to outreach to that patient. And what you can see here nicely demonstrated is that in the high-performing medical center, they perform well on the key drivers identified. And compare and contrast that now to medical center B, which does not do as well from an overall control rate. And what you can see now is that their performance on individual process measures is more variable. But importantly, you can now go to this medical center and say, these are the areas you need to focus on where you have the biggest opportunity. In this particular example, bringing the patient back in after an elevated blood pressure and then outreaching to patients is probably where their biggest opportunity is. So a very practical way of approaching gaps in control. So whenever we produce data, we produce it at the regional level, medical center, clinic, and individual provider. And I showed you previously the example of the repeat blood pressure, where every medical center was in the 90s, but as you begin to produce data at the individual level, as all of you know, you see some important findings here. In this particular example, this one nurse highlighted is only repeating the blood pressure 29% of the time. So very easy now for the manager to sit down with this nurse and to review their data and to hopefully affect some change in performance. We see this same pattern of more variation as we drill the data down more specifically. In this case, treatment intensification, where every medical center is in that 30 to 40% range. But now look at, as we see a particular clinic, this is one of my clinics in Los Angeles, and you see the tremendous variation in individual performance by physician between 5 and 65%. Very impactful. You can now go to physicians who may not have a good control rate and share with them their treatment intensification rate as a tangible way for them to improve their control. And then lastly, we use this in our health equity work. So I've told you that we've made some improvements in our black versus white disparity gap, but we haven't eradicated it. We've looked at a number of process measures, which all look fairly comparable, but what we found here is that medication adherence in particular is lower in our black hypertensive population. So that has led to a focus on this with increased inquiry during the office visits and some communication skill building. I want to bring this all together with work we've done in HEARTS and wrap up. So all of this information, the individual key drivers, how a system approaches this, was studied by a group of great participants from the 12 initiating HEARTS countries, as shown on this slide. And we met for a period of about a year. We studied a number of high-performing health systems and also used the CDC Hypertension Control Change Package, which I think is an incredibly useful compendium of best practices. We also incorporated the work of the WHO updated guideline in 2021 because we now have some specific examples and guidelines rather of what to do in situations where there previously wasn't necessarily evidence-based or guideline-based information for us. We put this all together. We published this data in Lancet Regional Health Americas. And this is a summary of that work. We have 5 domains. And within those 5 domains, the key drivers listed there. And within each key driver, there was a set of very specific recommendations, which were all put together in a scorecard, which we don't have time today to go over, but much of it we've covered, including things like treatment intensification and continuity of care. Blood pressure measurement accuracy is a big issue for our work in the Americas. And so there are some specific drivers associated with that, such as training of staff and use of validated monitors. But the idea here is to bring this all in a quantifiable, measurable way with goals and a point system attached. We roll this up into what we call the HEARTS Process Maturity Index, which is a 1 number, which then allows us to trend health systems and clinics over time, but also to compare and contrast systems so we can see where there are emerging best practices and need for improvement. We also continue to look at outcome measures. So we have a separate index called the HEARTS Performance Index, which looks at coverage and control. And we have a similar methodology for how to roll that data up as well, too. And then lastly, I think you're going to be hearing later in this series about the hypertension clinical pathway as part of the HEARTS program. But this essentially brings in all of the information of the key drivers into a nice 1-pager. So you can see at the center of this pathway is the medication algorithm, which really needs to be socialized with all providers and staff. But then you also bring in reminders and prompts for all of the other things that we should be doing for our blood pressure care. So it's great to have as a 1-pager. This can be posted in multiple venues and really allow you to socialize the concept of key drivers much more effectively. We have also created some courses. So PAHO has a wonderful virtual campus, and we've produced a number of modules on specific key drivers. So there's much more information for any of you who are available in both English and Spanish on PAHO's virtual campus. So in conclusion, I would like to stress that to improve blood pressure control, you not only have to measure control, but you have to really specifically identify those key drivers that will help you achieve a higher level of blood pressure control. We need to translate those key drivers into process measures, and then the system needs to create a performance feedback methodology so that frontline clinicians and clinics can get that data and respond accordingly. I hope I've given you some information about key drivers from both a system perspective and what some of the actual evidence-based key drivers are. There's a lot of evidence for these. They're very guideline supported. And this really, we want to stress, is not just an academic exercise, but we think this is a necessary part and a necessary process to improve your blood pressure control in your system, that these are very practical and essential tools to be able to do that. And with that, I will wrap up, and I thank you for your attention. And hopefully you found this helpful.